everybody. Welcome to a live webinar. My name is Dr. Chris Green with my dear friend, Dr. Thomas Reed. And we're getting the question a lot of how to handle insurance participation, not necessarily going fully fee for service, but even just if you want to just reorganize the way that you're contracted with insurance companies for the maximum benefit to your practice. So Tom, thanks for being here, and I'm going to go live with the presentation.
Yeah, no, thanks again on this awesome Friday to get together on a very hot topic and something near and dear to both of us as far as how we've navigated our way through successful practice management over the years.
Very good. So key considerations for dropping a dental insurance plan. Tom, give us a quick overview of your background and then your history with the insurance participation, because you've done it all.
Yeah. I have. I grew up in an era in dentistry when PPO or managed care contracts really got their foothold in the early 90s, and they were a mainstay, and it was really all we knew. And back then, the adjustments were pretty tolerable at anywhere from 10, 15%, or maybe upwards of 20% of your normal fee. And then slowly over time, that has eroded into what we actually experience today. But over that course of 25, almost 30 years, I have done everything from cut plans cold turkey to realize that was a miserable mistake, to sending out the albeit popular letter to the patient without any real plan in place. Again, a miserable disaster, to finally getting smart about it and realizing that there's got to be a systematic and pretty straightforward way in which to follow a path to success when it comes to reducing insurance dependency. And that's where we are today.
Yeah. And, I've been pretty impressed with your approach to go fully fee for service. For me, I'm not a fee for service office. We opened in 2018, and within 5 years, we collected close to 5 million on an annual basis. And our approach was, in the beginning, it was a complete train wreck. I said, hey, I need to negotiate my fee schedules. And at that time I was working with somebody and they said, oh yeah, we have somebody for that. I said, cool, don't have to worry about it then. So I handed it over, just to realize all they did was they pushed some paper on credentialing, did not negotiate any of the fees, put me in with everybody under the sun. And then also the credentialing was messed up. So my poor wife, I brought her in. She didn't know much about dental, and I was trying to spin the handpiece and grow this thing. And she unwound it, and she said, I think there's a better way. And then we came across a different approach of using umbrella networks. And what I chose to ultimately do was, we have a very strong kind of UCR fee schedule with and utilize our dental savers plan. And then we, in Colorado, we're able to go Delta Premier. And then we use a umbrella network called Carrington. And with that approach, and with a large, busy practice with an insurance conscious consumer in my area, we've been able to get really a lower percentage of write-offs and closer to our UCR, and everybody's happy, and so are the docs that work for us. So we'll dive into more of that as we go, but that was kind of my approach and my journey through insurance. I'm happy where we're at, but we're always looking for little levers to pull to get better and get reimbursed better for our valuable time and expertise, right, Tom? So
totally agree. And I think obstacles are always really should be reformatted in our brain as opportunities. And like I was mentioning earlier about going cold turkey back in the early 2000s, really was a exercise in, okay, what is a better alternative for us? And actually, that was the point in time when we started our membership program, our in-house savings program. And I feel like back then, we were probably one of the first in the metro area here in Denver to have actually implemented something of this nature. And it's stuck with me ever since. Even brought it over to a practice I recently acquired that is completely fee for service, to the point of actually assigning the payment of the insurance portion to the patient in the first place. And having introduced that program here, it's actually been a very, very popular approach, and actually a nice springboard to actually get some of these folks in this practice who are currently on dental plans off and onto our in-house savings program.
Yeah, no, that's awesome. And the savings program is a whole nother conversation, but definitely a meaty one to do it right. And there's a few different approaches. But for today, we're going to go kind of high level on whether it's dropping a single insurance plan or maybe a stepwise approach to going fully fee for service. This is just an overview. So if you need more information or want to do a deeper dive with us, book a discovery call. We run a small cohort of just like-minded dentists called Dynamic Dental Ascension. And in that group, we're all scaling practices, handling leadership situations, navigating the complexities of insurance and practice management. And it's a great group. So reach out to us, book a call if you're interested in diving in deeper, or if this topic, you still need further explanation on. So what do we need to know? When we're going to take on something, a project like this, which is a big one, we need to know ourselves. We need to get prepared. We need to know the data, which is huge. And there's two types of data we're going to talk about. We need to know the team, and then we need to know our community and the consumer. And finally, our mix of services. So like I said, this is not a comprehensive overview, but it's meant to help you make a more informed decision towards this. So I'll start with know yourself, and then Tom, will have you take the next one. So knowing yourself, this is an intentional process. It's not going to happen overnight. It's not an event. Tom already explained that, just saying, oh, let me just send a letter tomorrow to drop Cigna or something. That's not going to work. So you first want to decide, is my goal, to go fully out of network, so truly fee for service, or am I looking to just trim down some direct contracts, or do I want to utilize umbrella networks like I mentioned that we did? It all depends, but you got to know the data and know yourself and know what's the best approach. For me, I chose umbrella networks because we have a lot of associates, and I feel like in a fee for service situation, it is very relationship based. And when it's not the owner doctor providing the service, the patient may be a little more hesitant to pay the full fee. Tom, why did you choose to go fully fee for service?
It was a very long and heartfelt decision, having seen how hard we had to work to just overcome the gap between the actual fee that we had pegged to our service versus what we were actually receiving, and knowing that I couldn't make up for that gap and maintain the quality of service that I've endeared myself to provide, as well as what is expected of us in the marketplace. I just couldn't see staying in network or directly contracted any longer. And I think really what was the springboard for me was watching hygiene reimbursement just go through the floor. And at that point in time, it was just enough's enough.
Yeah, hygiene's the one that I think where we pay the biggest price for sure, especially with the way that hygienists are compensated these days. So another thing to keep in mind, is this going to be a long-term viable option for your style of practice? Are you doing this because it's popular? Because it really does seem like the in thing to do right now. Or is it because it truly aligns with your goals? Are you willing to put the time and effort in to properly train your team? Because this is going to require ask something more of your team, that's for sure. And is this the right time for your practice? So is right now the best time for it, or should you wait another year or 6 months or whatever? So only and in this, we're not going to be addressing anything about Medicaid, HMOs, TRICARE. This is that's just irrelevant for today.
So, without a plan, you might fail. And if you're going to fail, it's probably because you didn't have a plan. I don't know if that's the right way to phrase that, if it's a two-way street. But anyway, I am an Eagle Scout by virtue of my youth, and backdoored into that one out of the pressure from my father to complete the project. And I'm grateful to this day for that because it taught me so many valuable lessons in life. But being prepared is really at the core of the mottos of that organization. And I think it holds true to anything we do in this day and age that is of any worth or value and pursuit. So this is a very complex decision. I will tell you in retrospect, having been contradictory to myself and not being prepared in the past, I realized real quickly that hey, I better hold true to my own value system and get organized and get prepared. So there's a lot of common myths and challenges that go along with going fee for service, or really just maybe even what we like to call insurance friendly. Maybe you are no longer contracted with any dental plans directly. However, you still accept the responsibility of receiving payment for those services from the insurance carrier and working with the patient to figure out their copay. So it's really difficult, like Chris said, if you've got multiple providers in your practice, because that's going to require a volume of patients to come through the door and a busyness factor that really hits hard on the psyche of a ambitious individual. So in fee for service world, you're really talking about fewer well-planned visits and a lot more comprehensive scope to the care that you provide, and sitting and taking time to build rapport and relationships with the folks that have come in and sat in your chair. And once you go out of network, the insurance company is almost always going to send a letter that's going to state that, hey, you better go see one of our in-network providers, because not only will you save money, but you're going to receive top quality care. That may or may not be the case. We don't know that for a fact. That's not our place to necessarily be in that role. And so having a plan to actually go with is really, really important. In that way, it's organized and in a fine detailed fashion. It's really important to also know how much you might be willing to stomach in terms of attrition. I was talking to another client of ours this morning who was in a busy practice in a very nice community here in the Front Range of Colorado, serving the populace of that community, a decently educated net worth type community. And they elected to drop the 800-pound gorilla early this year in 2024, which is, in our case, Delta Dental. May not always be the case in your respective state, but Delta is the dominant force here in the PPO dental marketplace. And initially it was great, but what they noticed rather quickly was a massive drop off in patient flow. And so we've written here conservatively a 30% number that might potentially leave your practice to go up the street to an in-network provider. And I would tell you that that is something you should just assume or bake into your analytics, because people are price conscious in many cases, don't always value dental services beyond the commoditized nature that they feel it is, or have been led to believe by our community or by our economy. And therefore, they may or may not see the need to stay with you if they can go up the street and have a 30 or 40%, maybe even 50% savings off of the fee that you're providing for your service. So people will always pay for what they want before what they need, though. So keep that in mind and this is a long game concept, not a short game, quick fix. You've got to be able to market really well. So having a dental plan, savings plan in place is critical. And I think it's really important because you've got to have some type of medium in which to offer these folks an opportunity to stay with you and kind of maintain some similar semblance of what they've been accustomed to with their dental plan. In addition, I think you've got to be able to market really well to the community in order to replace this 30% attrition. And therefore, that's something you need to prepare in advance, is a solid marketing foundation prior to engaging in dropping contracts. And if you're going to stay in network, you've got to look at some creative ways to stack codes. Yes, I did say that here on this call, and there are effective and ethical and legitimate ways to do so. And there are alternative fees that can be added into the service that are literally reflective of the quality of the care that you're providing. And we tend to call those service fees, and those are perfectly eligible. They've been tested, tried and true over time, as well as being willing to get out of your comfort zone and expand your level of care, which we'll dive into here in a few more points. But that will get you out of the dependency on what are considered covered benefits and get into the non-covered and potentially UCR fee schedules.
And to a point you made earlier, I think mentally prepared for it to feel slower around the office, but it's kind of that work smarter, not harder mentality.
Mm-hmm.
So it's not like the goal would be that you're not making less money, you're making hopefully more, but with less butts moving through the office.
100%. I would just summarize that with, you may actually see a rise in the net income of the practice as a result of going fee for service, because you've eliminated the single biggest line item expense on a profit and loss statement that never shows up on that profit and loss statement, which is the insurance write-off. And once that's eliminated and you're back to full fee or near full fee, yes, your volume goes down, but the dollar amount per procedure skyrockets. And oftentimes, and it's been my experience, that your income actually rises.
So know the data. The data, this is probably the biggest part of the whole thing. In your analysis before making a decision, we need to know the data. It's going to require a little bit of legwork from you and maybe an office manager or a trusted team member. And I broke this up into the hard data and what I'd call soft data. So the hard data is where you could kind of grab real numbers and throw them into a spreadsheet. So what we like to do is we like to make a chart of the top 20 codes and compare each fee schedule. And also remember to include a column for your UCR and your dental savings plan fees. So we can actually compare apples to apples and see where we're getting hammered on these different fee schedules. Again, hygiene, very, very important. Those codes, you might look at that as a bundle. So you might say, what's the total cost with this carrier for a adult pro fee, a periodic exam, and 2 bite wings or 4 bite wings or whatever your typical protocol is, and compare those. So you're comparing apples to apples. Determine the total number of patients under each fee schedule. And then what is that based on what percentage of the total patient base is made up by that carrier? So example, I have 1,000 active patients. I have 300 on Cigna. 30% of my patient base is on Cigna. The current number of patients with no insurance or on your dental savings plan / out-of-network patients. This is important because if you already have a big number here, maybe your team's already doing a good job. Maybe you're already doing a nice job attracting patients that are out of network. So maybe this won't be quite as hard as you thought. I would look at your write-off amount by fee schedule. So look at the percentage that you're writing off. Is it 20% or 40%? If it's 20% and you're offering 15% off your savings plan, maybe that's not so bad. Whereas if you're 35, 40%, that could be tricky. And some of us have positioned our UCR fees really high, so it looks like the write-off's a little worse than it is, but that's kind of done intentionally to show insurance companies what our real fees are. So, and also to combat some of that 15% write-off with the savers plan.
Mm-hmm.
What are the new patient trends over the last 18 months? So what insurance are people coming in with? Over the last 18 months, maybe you saw an uptick in people on, I don't know, United Concordia or whatever it may be, but look at the trends and then know your cost per procedure and profitability per procedure, because this is just something you should know regardless. So
Real quickly on that.
What's that?
Real quickly on that last page,
Yep.
I just would reiterate that want to make sure that our full fee schedule is in the computer properly, or in the practice management software properly, and that is the amount that's getting billed to the insurance carriers. because oftentimes these practice management systems are set up to help adjudicate claims. That's to simplify the collections process on the back end. And so very often a dental office is likely not fully aware of how much they're actually writing off in respect to the difference between UCR fee or their regular fee and that contracted fee, because they're submitting contracted fees directly to the insurance carrier. So it doesn't look like there's that big of a write-off. What I would challenge you with is that I can almost guarantee you that it's a bigger gap in that instance because they aren't aware, but the practice's overhead and the cost to deliver care has been pegged to a much higher number in order to get to that net amount. And so that's a real eye opener for many. And that's a function of most practice management software programs are set up on the collection side and not on this side of the equation.
Good point. Very good point. So knowing the data, the softer data, this kind of requires further digging. So we mentioned already, but assessing the potential patient loss, we're kind of guessing, could I handle losing 30% of the patients that are on this fee schedule or with this carrier? Spot check the names on the list of the insurance that you're considering dropping. One time I spot checked the list and I said, boy, I really love these people. I would hate to lose them. And maybe they wouldn't have left me, but it kind of swayed my decision to say, I'm going to drop this insurance instead of this one because I see more challenging patients on this other list. I know that's a little bit, I don't know, maybe a gray area, but honestly, like we're just trying to enjoy our, make the most of our day in the workplace and make our team's lives easier, right? If we have a subset of patients that are always calling, complaining about bills when, it's really not our fault, it's the insurance not being transparent, maybe we need to consider less of that avatar. So anyway, denial rates, some of these carriers deny everything. Right now, Guardian denies every SRP no matter what. It is out of control. So we're thinking about dropping Guardian because I only have about 70 patients on it. I basically had to tell every Guardian patient right now, you're going to have to pay up front because they're going to deny it. I just guarantee it. You have perio, but they're going to deny it. And that's, these are the things that we face. So you got to know the data from your team. What is the time required for the team to get breakdowns, appeals, processing of claims with this? It's for example, Blue Cross Blue Shield is a nightmare to get a breakdown from, and they have this grid network and on and on and on. So maybe Blue Cross is one where I don't really care so much if I don't get a ton of patients from Blue Cross. At least, that's been our experience. And then region specific considerations, Delta is different in every state. I know in California and Florida, it's really, really bad fee schedules. But in Colorado and others, we can still get on Premier only, and it's not so, it's not so bad. Although I'm sure people would argue with me on that one. If you're on Premier in Colorado, it's not completely horrible, in my opinion.
One other thing I'll throw in there from more anecdotal is expect to be surprised a little bit. I think Chris, you alluded to this earlier about spot checking names. Don't be surprised by people you thought were as loyal as the day is long to your practice. They end up jumping ship for an in-network or a corporate group up the street or some type of insurance-driven jump. And then you have the folks that maybe you thought, well, gosh, they're not very loyal or aren't very compliant, or maybe they don't make it high on the favoritism list of our teams, end up staying through thick and thin. I've experienced that firsthand, and I've heard that from many other clients over the years who have gone through this process with us. So,
well, likewise, you'll see people that left for a recall cycle or two and come back, or
absolutely,
maybe their employer changed and they change insurances and come back. I think,
or they go up the street and don't have the kind of experience they've come to expect from you. I mean, I think you hinted at this earlier. It's a relationship business, and we're in the business of trust. And dentistry is one of those uniquely nuanced services that we provide. And when it comes to healthcare, it perhaps is one of the more technique and personally sensitive services that gets provided to the people. And people are kind of particular about that. And if they're not treated well and you are treating them well, just remember that someone up the street might be nicely marketing in a way to get them to come back to you based on the way they operate. So I don't think you can change that. Once you've got a standard at which you operate at, you're going to always operate at that place.
Sure. So I wanted to share this, not because it has to directly do with today's presentation, and I know this looks like a lot, but annually we should be raising our UCR fees. And in my experience, you look at one of these code books, and it's it's an inch and a half thick, and there's codes that you never even bill. So what I made for our team, I said, what are the codes that we're going to bill 99% of the time? And I made these two sheets. It's front and back laminated for my treatment coordinators. And it's like, if it's not on the sheet, we're probably not going to bill it. But then at the turn of the year, I could go in and customize how I update, and increase the UCRs. Now, I know you could go in and increase your UCR by, let's say, 5%, and it'll raise all the fees 5% annually. But in my experience, there's certain fees that we want to be more careful with raising, especially when we have more people that are on like our dental savings plan or things like that. People are very conscious of like the hygiene codes. So anyway, hope that tool is helpful. And this is how we kind of laid it out. Okay. Next, we need to know our team. Do we currently have the right people in place? What do I mean by that? If our team is not A+ in their communication, it's going to be hard to communicate to patients our out of network status. So, human capital is critical to the operation of a dental practice, regardless of insurance profile. And the team is essential for executing the systems, answering questions, and delivering the value statements of why the practice is making the out of network move in the first place. We need to ensure that their phone skills are up to snuff. We need to be involved in team training, role playing, reviewing phone calls, things like that. Especially new patient phone calls. We want to keep the conversion rate on new patient calls high. We want to have a frequently asked questions list, which Tom and I have one. If anybody's interested, reach out. The questions like, can I still see you? What will my hygiene visit cost? Do I have to do anything differently? So, and finally, like I say, can the team convey the value of your services?
Yeah, I think it's critical to not underemphasize the value of the team. This is certainly your vision as the practice owner and ultimately your decision. But without a team supporting you on this process, it gets kind of rough because, quite frankly, one of the first questions that always comes up on a phone call is, do you take my insurance? And I think having an effective plan in place on how to deflect that and sort of not disregard it, but downplay it in the series of the discussion with this patient on the phone is what leads to a better relationship. And remember, the patient experience begins before they even set foot in your office. So they're going to get a little reference to your practice, check out Google reviews, look at your website, check out the About the Doctor page, and then make the phone call. And that phone call is critical because they're going to be thinking, well, I'm going to use my hard-earned dollars here to take care of my health, my oral health, along with potentially my family. And I want to know that I'm getting a good deal, a good value out of it. I mean, you can't blame a consumer for that, and I think a lot of people just automatically think that people on dental plans are a bunch of cheapskates and are not dentally aware or intending to have high quality care. That's really not the case. And, in many cases, they just are given this benefit through their workplace and their employment. And it's a courtesy, it's financial assistance for them. So we're here to help them optimize that. But without a great team, you're not going to be optimizing it for these people, and they're going to go elsewhere.
Exactly. Let me Why don't you take this one, Tom?
Yeah, it's just as a continuation of what I was just saying. You got to know where you're at. Where does this practice reside, and what type of a demographic base does it serve, and who really is coming in to see you on a regular basis? Listen, nobody wakes up in the morning time, at least the last I checked over 30 years, and says, you know what? I think I'm going to go to the dentist today, and I can't wait. It's not, there's just no logic or rhyme or reason to that. People come to us for reasons other than that, and that's mostly out of necessity because they're in pain or discomfort. Perhaps they are compliant, and it's just time for that continuing care visit. However, the anxiety and stress and uncertainty that rests naturally in there, in that experience, is high. The trigeminal nerve is perhaps one of the largest, if not the largest, cranial nerve in the system, and it delivers a lot of information back to the head, and a lot of not so good information sometimes as a result. And the stuff coming back to it results in a lot of wear and tear and destruction that we get to fix and deal with. So, and it's a joy and a privilege to do that on a daily basis. But you got to eliminate the variables, and one of them is dental benefits. And I think when you think about it as financial assistance more than it is a necessity, it really changes your perspective, and
Yep.
you can reach these people in a more effective manner and have a conversation about it. It's not like it's taboo. People are transactional in our society today, and that's just the way it is. Our economy is a consumer-based economy, and people were always looking for a good deal. Well, the most deflationary effort or force on your efforts to run a successful dental practice are some of these haircuts that come from the dental plan. So managing it and navigating and staying ahead of it is critical. And you want to serve people that want to be in your practice. So knowing your consumer and finding out what makes them tick, connecting with them is critical. And you can do that with dental plans, whether you're in or out.
I like what you said here. Finding and attracting patients for reasons other than dental insurance is the cornerstone to an effective marketing plan.
100%.
All right.
So,
Know the mix of services. This is you again, Tom.
okay. I think in this day and age, and I say this as a seasoned clinician, it is the era or the day of the super GP in so many respects. I'm not saying that specialty care is out and nor should be taken seriously any longer. There's absolutely a limit to how much or how skillful we might be as clinical providers of care, but I think it's worth taking a serious inventory and serious look in the mirror about who you are as a clinician and what you're capable of doing, and maybe challenging yourself to do more. Once you get outside of the bread and butter realm of clinical practice, you start to get into opportunities where dental benefits really don't even exist. So that's why we talk about the mix of services as being critical. A lot of consumers want a one-stop shop. How many times have you heard, "Hey doc, can you just do that here for me?" They don't care how much you know. They just want to know you care. So at the end of the day, if you can do that molar endo and do it well and do it efficiently, and along with it complete the buildup and crown for it, you not only have you saved that patient a lot of trouble with travel and expenses, but you've also added a lot of revenue to your own practice operation, and you've done well by them as in addition. I think it goes without saying that oral healthcare is a critical part of overall health, and we have to be comprehensive oral clinicians or physicians and really integrate that into the patient's overall livelihood and kind of get them to co-discover with us what it means to be truly healthy. And once you do that and you add these extra services on board, it really changes the game for the better.
For sure. All right, some closing thoughts here, and thanks for sticking with us. This is a hefty topic. We could talk for hours on it, really, but I think at least this overview will get people a head start on making the decision. So, for the best possible transition, consider a 6 to 12 month planning period before notifying insurance providers or patients. Well, sometimes we're going to consider during that 6 to 12 months, it's a knee-to-knee conversation with the patient. So This slower timeline allows for 2 recall visits during which you can have in-person conversations with patients, explaining the reasons and benefits behind the change. It's important to anticipate that once notified, the insurance carrier will likely send a letter to patients discouraging them from staying with your practice due to potential out-of-network fees. So that's what happens. You send the letter to insurance and tell them, hey, we're dropping you. We're going out of network. Patient gets a letter very quickly saying, hey, you're paying too much to see this person. Consider an in-network provider. So our ability to explain the misinformation that's given to the patients and the miseducation is critical. And so, Tom, you have actually done this. You did it with the big elephant in the room that starts with the letter D. Tell me how you guys tackled it.
Yeah, no, thank you for that. I will tell you that the face-to-face conversation is the only way to make this work. And I don't think it really is exclusive to the 800-pound gorilla in our PPO contracts. It is truly beneficial to all. And I think if you have a plan in place and it includes sort of a systematic approach, you're going to start with some of the lower hanging fruit and some of the smaller contracts and really work side by side with these patients and get your saw sharpened a little bit so that when it comes time to tackle the behemoth, you're ready. We spent almost 9 months face to face with those patients in that program and really visited with them personally, and even went as far as sending out a letter after communicating with them, and did it digitally with email as well as in handwritten format. And it still was confusing to these people. And when they received their letter stating that, exactly as you said, you should stop seeing this dental office because it's too expensive for what you're getting, they were even more confused. And so I don't think there's any shortage of communication that can be helpful in the process, but no matter what, you're still going to have plenty of sort of ambiguity associated with it. And that was our experience. And I will tell you that we probably saw attrition in the neighborhood of 30% ultimately from cutting ties with the largest dental PPO provider in this state.
Well, I think a common mistake as well is sending the letter directly to, your own letter to the patient before getting to talk to them. So
Correct.
I like that you printed the letters out with FAQs, very, very clearly written and defined. And you'd sit knee to knee, explain the letter, and physically hand it to them. And then, maybe after the 12-month period or the 9-month period, you also mail them a copy. And then finally, you send the letter to the insurance carrier that you're looking to drop. That would be a key consideration, rather than they get the letter from you, they're confused unless you actually get a chance to explain it a little bit.
Correct. And, by the time they get the letter from the insurance carrier, they've heard from you several times, hopefully.
Yeah.
Bear in mind, there will always be some that slip through the crack. Maybe their compliance rate isn't outstanding and they haven't been in a while. Now all of a sudden they show up and you're in your schedule and you're no longer contracted, and you have to have that discussion right then and there. I think honestly, that's the type of situation where you take it on a case by case basis and you say, you know what, Mrs. Smith or whoever that person may be, we understand that you missed our communication. We're going to honor what you expected for today. Just know that next time you come in, this is how it's going to be going forward from here. But today we'll honor that with you. And I think there's a lot of flexibility and nuance that we can apply to that, and certainly continue this discussion in greater detail. So I think if it's sparked interest in anybody who's watching this, I would say jump on a discovery call with either Chris or myself, and we'll can walk you through your specific situation, because it is I think dependent upon location, and it can be done in any marketplace, whether it's a high density populated metropolitan area to very, very rural parts of this country. It's all possible.
Well, thanks, Tom. That was great. We hope this was valuable, and we hope to hear from you if you need anything.
Mhm.
Thanks, guys.
Yeah, have a great day.